We are presenting the results of translational research on PETACC8, which was a large adjuvant trial testing FOLFOX plus cetuximab against FOLFOX. And we here have an NGS assessment of 1,800 tumors from this trial. And what we have shown is that even with purifying for BRAF wild type and RAS wild type, full RAS wild type, our patients, there is a trend to benefit to cetuximab in the adjuvant setting, but this does not reach significance with a p-value of 0.1, which is not far away but not succeed. And we also have a trend to a deleterious effect of cetuximab in mutant patients, which once again doesn't reach significance. The NGS assessment also allowed us to see the very rare BRAF non-V600E mutation and the very rare RAS mutation, showing that there is no prognostic value for this rare mutation as compared to exon 2 KRAS mutation and BRAF V600E, which are prognostic in stage 3 colon cancer. So this is the first time we have these results on these very rare events. And we also have identified the HER2 positive tumors for colon cancer, which represent approximately 5% of our patients. And this seems to be a very strong prognostic factor in the adjuvant setting. So maybe this will open some trial for the HER2 positive with anti-HER2 drugs in the future. The toxicity in the adjuvant settings were really what we expected for with the rash, skin rash. We know that now with prophylactic antibiotic we don't have a lot of severe rash, and generally it's grade 1 or 2 maximum. We don't have any more grade 3 and 4. And if you do it prophylactically and not reactively, it's very efficient. So what we have seen now in the metastatic setting, not in the adjuvant setting, is there is a big buzz about the sidedness of the tumor, right versus left colon cancer, which reflects probably very molecularly different tumors. And what we have seen is now that we have a lot of data showing that anti-EGFR, whatever cetuximab or panitumumab, do better than Bev on the left-sided tumor. On the right-sided tumor, the problem is that it's only 1/3 of the patient, and it's post-hoc analysis of subgroup of patients. So it's really small groups. It seems that in some trials, cetuximab or panitumumab do worse than bevacizumab in this setting, but not in all, and the numbers are too small to conclude. So I think that in the future, pooled analysis of all this data will help, and maybe we will have to drive some clinical trials from right-sided colon cancer to compare the two targeted agent families. So I think that now in the future what we have to do beyond right and left, which is a bit an old way to classify the tumor, is to move to general molecular assessment of the tumors. It's already done with consensual international classification, what we call CMS, in colon cancer with 4 different groups, and I think we have to implement that and also to look at precise factors such as methylation status or what else beyond BRAF and KRAS, which are already done, and MSI also, which is already done, to try to improve our molecular classification and to categorize patients for the good treatment.